Good morning to all. My topic is scleral suture fixation for subluxated capsular bag IOL complex. This comprises in situ fixation in the scenarios like closed loop haptic subluxation or when there is a fibrosed anterior capsule. Then subluxation with IOL bag plus CTR inside, and subluxation with IOL bag with CTR and CTS, that is capsular tension segment with Gore-Tex suture. Let's move on to the video. Audio.
8 degree apart. Inferiorly AC main tunnel is used and superiorly main tunnel is made. Here one arm of the dienceroproline is passed via the ciliary sulcus, and this passes through the closed loop of the haptic and is reintroduced back, docking inside a 26 gauge needle, and the same procedure is repeated on the other side as well. The needle is docked in the 26 gauge needle and taken out. Now the two suture ends are sutured, and it goes beneath the scleral pocket and is not exposed. The second case is in situ fixation through fibrosed anterior capsule. Here a small conjunctival peritomy is made at the temporal limbus. Scleral vessels are cauterized and 3 mm is measured using a caliper, and from the limbus, 3 mm from the limbus, partial thickness scleral pocket is constructed. Now opposite to that, side port is made and a gentle manipulation of the IOL complex is done. Vitreous presence was noted and vitrectomy done. An inferior side port is made for the anterior chamber maintainer so as to avoid using OVD. Now, one arm of the 90 double-armed proline is introduced 1.5 mm from the limbus at the ciliary sulcus into the anterior chamber. At the same time, from the opposite end, the 26 gauge needle, which is bent at the hub, it is introduced, and the needle is railroaded into the 26 gauge needle and taken out. It is exteriorized through the opposite side port and the needle is withdrawn. Now the same needle is reintroduced via the same side port using a micro forceps. It is introduced into the anterior chamber, and at the same time 26 gauge needle is introduced at the ciliary sulcus at a different site. The 26 gauge needle, which is bent at the hub, as you can see, it is introduced at the optic haptic junction where there is a fibrosed capsule. It is just kept, and the needle is railroaded again very cautiously into the 26 gauge needle and withdrawn from the same exit. Now the two suture ends are noted in the conventional 3-to-1 looping, and the suture tension is titrated. At the same time, position of the IOL bag complex or the IOL is checked and the suture is tightened, and now the knot goes beneath the scleral pocket. The ends of the suture are cut and it is within the scleral flap. The conjunctiva is reposited back and cauterized. AC maintainer is removed and all the side ports are hydrated. The IOL is looking fine now. Third case is subluxated IOL bag with CTR inside. Here you can see a grossly subluxated IOL bag with the CTR placed inside. Now a gentle manipulation is done. Here after conjunctival dissection, meter from the limbus, a scleral pocket is constructed. Arm of the 9 proline suture is threaded by the anterior leaflet of the capsular tension segment, and at the same time the gauge needle is introduced at the ciliary sulcus, and the needle is introduced and docked inside the 26 gauge needle and taken out. The second arm of the 9 proline is also introduced in the anterior chamber, and now the 26 gauge needle, it is again introduced at the adjacent site, and the Second arm is also docked inside the 26 gauge needle, which is bent at the hub and taken out via the same opening. The capsular tension segment goes inside and it tabulates against the area of maximum dialysis. The same procedure is repeated on the other side as well. Here also the capsular tension segment, another one is introduced, and following the same principle, it is also introduced in such a way that it tamponates against the area of maximum zonal dialysis. At the same time, the IOL position is also confirmed. Knots goes beneath the scleral pockets and the visco wash is done. Fourth case is fixation using Gore-Tex suture where there was a CTR and CTS inside. Here two scleral pockets are constructed temporarily and nasally 3 mm from the limbus. Now the capsular tension segments are gently disentangled from the bag using a Sinski hook or dialer introduced from the main port in the presence of a viscoelastic material inside the anterior chamber. Now, 7-0 Gore-Tex suture, it is introduced via the temporal scleral pocket is threaded through the anterior leaflet of the opposite CTS, and it is withdrawn with the help of a 26 gauge needle which is bent and it is docked inside and withdrawn from the other side. Other arm of the Gore-Tex suture, it is also introduced and withdrawn using a micro forceps from the nasal side. The two ends are out at the nasal scleral flap now. Now the temporal side also, the capsular tension segment is disentangled and the first arm is passed threading the anterior leaflet of the capsular tension segment and it is withdrawn docking inside the 26 gauge needle from the temporal scleral pocket and withdrawn out. Now the other end is also withdrawn at the adjacent site using a micro forceps. Now the two ends are also out at the temporal side and the suture goes beneath the scleral pocket.
I mean, it's a case of escalating complexities, and all your cases tend to, get displaced, decentered with time. So, you first said we use a double arm suture. In the first technique,
Yes,
actually, even a single arm suture, because you again reintroduce the needle through the same port. So, I think even a single arm suture actually will work.
Okay.
About the last case that you showed,
Yes.
what happened to the original suture, the proline one? It got cut, is it?
Yes, sir.
It got cut on either side.
Sir, it was already cut. It was initially it was the third one was using 90 proline, and the last one is using Gore-Tex suture, sir.
No,
Okay.
we are asking what happened to the original suture that fixed the CTS to
Not on either
sclera.
side. On either side, it got cut, is it?
That is a different.
No.
Yes,
The segment. See, normally a CTS is suture to the sclera.
Okay, sir.
Okay. Here we just saw the segment without an evidence of suture. Number
Yes,
one.
sir.
Number two is in an old situation, like after 6 months to 1 year, the capsule actually anterior and posterior capsule will stick to each other. It's very difficult to open up to introduce the CTS back into the capsula fornix
Okay.
or the equator of the lens. So this is a very, a lot of heroics. I really should appreciate the surgeon, and you have really documented it and demonstrated it very well. And in the retrospect, in the hindsight, do you think these cases must have been a PXF or some kind of a zonulopathy which must have been progressive?
Yes.
Would have been a good idea to probably put a 3-piece lens in the sulcus and capture it rather than put a single-piece lens in the bag, which you had a series of cases which all decentered later.
Yes.
So in the hindsight, what would you do if you don't want to have such situations? Well, your series will grow, but if you don't want that to happen.
Sir, three-piece IOL will be a very good option, sir.
Because it's a very documented thing that you're going to severe PXF, even
yes,
though you're
sir.
able to put a single piece lens in the bag, which will again to decenter later. You would always put a three-piece lens
Yes.
in the sulcus and capture it, which will be better for a long-term centration.
Yes, sir.
Okay, well done.
Thank you, sir.
So, Dr. Ashwati, Neena, Satish.